when the boys are diagnosed. So I know that our clinic wants the boys to be weight bearing, to walk as much as they can while it is still safe. And at one point, of course, it's not safe. The boys are more likely to start tripping or falling and breaking things. But until that happens, we would like to encourage weight-bearing activity. Normally in healthy children, bones grow and get stronger by the pounding of the body on the ground. So that sort of shock that happens when you step and make a step, or when you jump, or when you play soccer, those little bounces on the ground send literally a little electrical waves through the bones, and that's what makes them harder. As you can imagine, the more immobile you get, and then once you're in a chair, you're not having those bouncing actions, and then the bones don't sense that and keep as strong. Things like swimming are great for flexibility and keeping strength up and things like that, but unfortunately, because they're not weight bearing, they're not as good for the bones as they are for all of the rest of the body. It's very important for kids to have good calcium intake. So bones are made of calcium. So just like any other kid, the diet needs to have a goodly amount of calcium in it. If you can't have dairy products, then we do normally encourage calcium supplements. And again, vitamin D is also very important for bone strength. And living in Canada, we don't get as much sunshine as people who live in Florida, for instance. And so we recommend that all boys start on 1,000 units a day, and they may need more, like maybe sometimes 2,000 units. And we do check the levels in boys just to make sure that they're at a good level. And in Canada, the number is 75. You would like your vitamin D level to be 75 or more. Where can you get calcium and vitamin D? Well, BC HealthLink has got an excellent handout that we give families when boys or girls aren't able to consume enough calcium in their diet, say they can't tolerate milk products. But this is a really nice handout that's easily found on the internet that gives you ideas about where you can get calcium and vitamin D from your diet. Vitamin D, really, you probably should be taking a supplement. And I know our kids do meet with the physiotherapist and the dietitian, and this is where their help is really invaluable. How do we monitor for osteoporosis? Well, we ask kids about back pain, whether they've had fractures, whether they've injured themselves and not had a fracture. And that's something that really should be asked at every visit. And I know that happens in a neuromuscular clinic, and certainly happens in our clinic as well. The guidelines say that kids with DMD should have an x-ray of their spine every 2 to 3 years before they are started on treatment with deflazacort or prednisone, and at that point, every 1 or 2 years afterwards. And I know that's the policy at Children's Hospital. And then at some point, the boys should be getting bone mineral density studies every year. And just in case you don't know what that looks like, this is a bone mineral density study of a boy with Duchenne's that I've known for a long time. He's now 17, and this is his spine. So the program is measuring how much calcium is in these four segments of his spine, these 4 vertebral bodies. And when I met him, so the top blue is the upper half of normal, the darker blue is the lower half of normal. This boy, when I met him, was still okay, but then things started to drop off. And this was just around the time we started using treatments for osteoporosis. And as you can see, this kid's bone mineral density has gone better, 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 better. He's been able to maintain not a normal bone mineral density, but enough to keep himself from having pain and having more fractures. This boy actually has a fracture here. You can see that this one, L1, is not as tall as the other. So this is one vertebra that did get crushed along the way. Here's another one up here you can see. So how do we treat osteoporosis? Well, we use a class of drugs called bisphosphonates. And bisphosphonates are drugs that were initially designed for little old ladies who have osteoporosis and are starting to get a more and more curved back. They've been around for a long time. And about 20 years ago, people started using these medications for children, first with brittle bone disease, which is a more common condition. And pretty much everything we know about bisphosphonates in children, we know from children with brittle bone disease. We do not know nearly as much about how best to use them in boys with Duchenne's. The first drug that we had was called pamidronate, and then about 5 to 10 years ago, we started using a more potent drug called zoledronic acid, but they work the same. Zoledronic acid is just a little bit easier to give because it's a single infusion every 6 months. They are given by IV infusions. There are pill forms of these medications, but they don't work nearly as well. So we've stopped using them. We just use the IV medications. And what they do is they basically slow down the breakdown of bone that is being caused by the glucocorticoids, by the steroids. For those of you who have a son who's taken zoledronic acid or pamidronate, you know that they can get sick, particularly with the first dose. And it can be a very nasty flu-like illness. But most boys, if they get past the first cycle of medication, they generally don't have too bad of side effects after that. Sometimes a little headache, sometimes a little muscle ache, but it's usually not too bad after that. We still do not know the best dosing regimens to treat boys with DMD, but the one that we use is the same as the one for brittle bone disease, and it seems to help reduce the number of fractures that the boys are having and to decrease their pain. And if they're given every 6 months, most boys will remain relatively pain-free for about 6 months. We do not know when to stop these medications. So theoretically, boys with DMD are going to be on steroids for the long term. And so the current plan is to continue these medications, perhaps at a lower dosage, but to continue these medications indefinitely until we have more idea about what's the best plan. But most boys or young men, when you stop the treatment, they start to get backaches again and start to get more fractures. So those of you who are children's hospital patients in Vancouver, you know that we have this handout that basically talks about how zoledronic acid works, but also how to manage the symptoms that you might get, particularly after your first dosage. And just to give you an idea of what's happening, how this medication is working, this is a boy who at 11, a boy with Duchenne's, already is starting to get some fractures, some flattening, some smashing down of his bones. 2 years later, it's gotten even worse and things are even more squished. And but this boy has then started on pamidronate, which was the first drug we had. And really things haven't changed from 13 to 16. They're not getting worse. And by another 3 years later, you can see that while these are completely not normal, they're definitely harder looking. They're whiter, more calcium than they were when we started. So this is a boy who has been able to preserve and not get new fractures and actually have a little bit of buildup of his old fractures. Our next area is delayed puberty and growth. And this is a result of, again, the steroid treatment, because we know that prednisone and deflazacort inhibit our production of growth hormone and inhibit our production of puberty hormones. And those are the two hormones that everybody needs to grow and to go through puberty. And many of the boys who are on deflazacort are quite late or non-existent with their puberty, and they remain quite small. There's really no way to prevent this with the steroids. There's no steroid treatment that doesn't do this. So there's no really way to prevent this, but we do sometimes treat boys with testosterone to help them speed along their puberty. Testosterone is most easily, honestly, given as an injection, as a little tiny injection every 1 or 2 weeks. There is a daily gel that's also available, but actually most people find it a bit of a nuisance. The good thing is, so that definitely works to have boys go through puberty. It helps with their bone health because much of bone calcium happens when you go through puberty. And a lot of the boys are just not happy about looking like little boys. They'd rather look like young men their age. And so, of course, there's a big psychosocial benefit for some kids to go through puberty more or less the same time as their friends. And again, because the steroids is a lifelong treatment, so is the testosterone. You might ask about growth hormone. Growth hormone studies have been done in boys with DMD, and they really haven't made much of a difference as far as boys growing or bone strength or anything like that. And growth hormone treatment is extremely expensive. And then, unfortunately, the last problem that we have to deal with is perhaps the hardest, and that's the weight-related problems. We know, and I'm sure everybody has seen this, whose son is on steroids, but it makes you hungry. It makes you eat more. It increases the ability to put down fat tissue. And as that happens, as boys get heavier and heavier and less active, this then leads to problems with blood sugar, cholesterol, blood pressure problems. These may or may not happen when the boys are still with us, when they're still in the pediatric age group, but as time goes on, these problems get more and more frequent. particularly if you already come from a family where there is a lot of diabetes or cholesterol or hypertension, high blood pressure things. So what can we do to prevent this? Well, this is really, really difficult. Try to maintain a healthy diet where the boys are eating about 70 to 80% of the caloric intake of their friends. This is hard to do because boys on prednisone or deflazacort are really hungry. And of course, we want to make life joyful for kids as much as we can. And sometimes that means probably having more treats than we should be doing. I understand how difficult that would be to say no to something like that. Try to keep the kids active, again, as much as tolerated or as safe. Dietitians and physiotherapists, again, can be really, really helpful in trying to figure out ways to keep the weight gain down a little bit. And at some point, for some of the boys who are well on their way to getting diabetes, type 2 diabetes, we will institute the drug for type 2 diabetes to prevent things from getting worse. So just as far as monitoring, all boys need to have their blood sugar checked, their cholesterol checked with time, their blood sugar and blood cholesterol and blood pressure checked. And then as doctors, we need to follow for some of the other problems that can happen with overweight, sleep apnea, reflux, and sometimes, again, social isolation. There is a little bit of hope for the future. We're hoping as time goes on that we will have better information about how to keep bones healthy, whether in fact we can entertain the idea of stopping the bone treatment for a little while. So far that doesn't seem to work. Perhaps someday we will have a better idea about the best dosing regimens to do for boys with DMD. And we're also hoping that down the road, there may be newer drugs to help strengthen bones in a different way that may work in conjunction with the treatments we're already using. We're still learning about puberty and growth in boys with Duchenne's. And of course, there's a whole number of new treatment medications out there for adults with type 2 diabetes that sometimes cause less problems. And of course, the Holy Grail is a treatment that requires no deflazacort or prednisone. And I know that there are talks at this meeting about that very topic. So I will finish my talk right there and return the screen back.
Thank you very much indeed, Dan, for a beautiful overview of the challenges that we have when we're treating our children with regular glucocorticoids. And as you were right, we'll talk a little bit more about non-glucocorticoid steroid later today. I'm going to pass back to Rochelle, as I understand that our orthopedic surgeon is going to be talking hopefully tomorrow rather than today, but I'm going to pass that back to Rochelle so we can see where we're going at this point.
Thank you, Dr. Selby. Yes, unfortunately, hi everyone. Dr. Riley is unable to join us this morning, we just heard, but he will try to join a presentation. We might try and squeeze one in tomorrow during lunch hour, so he has the opportunity to chat. But at this moment, we're ending on time. So we actually made up some time, which is amazing, thanks to Dr. Metzger. So we do have about a half an hour to have that coffee break and to go into Dr. Metzger's room. What I'm going to ask is maybe if Dr. Selby, if you want to join the other room, and then we can have those two coffee breaks running at the same time. And so people have the opportunity to maybe chat with Dr. Selby. If Dr. Riley can't attend the coffee break, we're just waiting to hear. And then others can go into Dr. Metzger's room. And then we're going to have a short break for lunch. I just wanted to remind everyone before we go into the coffee break, speaking of lunch, it is short, but we do recommend maybe taking a few minutes over your lunch, half an hour, to go into the sponsor session. We have one sponsor in particular, Ital Pharmaco, and Anna Christensen, and she's going to be live online during that half an hour lunch break to be able to answer questions about the current pipeline in Ital Pharmaco and help to answer any questions on patient support programs. So I would encourage you to go into the sponsor section, go and chat with Anna during this half an hour lunch break. But first, let's go into the coffee break rooms and let's chat with Dr. Metzger and also Dr. Selby. So I will end this session and we'll see you in the coffee breaks in a minute. Thanks, everyone.